Hello and welcome to Indus Special. I'm Meshal Malik. According to the World Health Organization, after every 40 seconds, a person in the world commits suicide. Moreover, according to certain indicators, for each person who dies due to suicide, there are 20 others who attempt it. The ubiquity of suicide is not restricted to any one region, gender, or age, and a conversation regarding it is necessary, and that's what we'll try to do today. We're joined with Dr. Ali Mehdi Hashmi, an associate professor at King Edward University, Dr. Sadakat Ali, who's the project director of Easy Interventions and Willing Ways, and Dr. Atishri Bhatti, who is a clinical psychologist from Delhi. Thank you for joining us. So, I mentioned how after every 40 seconds, a suicide takes place. So do you think there is an underreporting of suicide rates?
Yes, absolutely, Mishal. I think you were talking earlier about the fact that maybe you want to look at it from a global perspective. So globally, suicides are underreported because generally it's considered a source of shame or there's some stigma attached to it. Oftentimes suicides or sometimes suicide can be misreported as accidents, so auto accidents and things of that sort, which are actually suicides, can be reported as something else. It's important to mention that in Pakistan, there is a significant, one significant factor which causes a huge underreporting of suicide, which is that the Pakistan Penal Code still considers suicide a crime. So suicide is not only not acknowledged as suicide, it is avoided because family members know that if police or law enforcement or even health authorities find out that a person has tried to commit suicide, then they can be prosecuted under the law. Police can start bothering them, start registering cases for them, and then you know how the police system in Pakistan works. Going to thanas and kacheris and bribed and this, that, and the other. So it's a huge burden for family members, not only to have to deal with a person who has mental illness and may have committed suicide, but then also to deal with the legal repercussions afterwards.
Dr. Sadakat, do you think that suicide rates are higher than they were perhaps 10 years ago?
Yes, definitely suicide rates are on the increase all over the world due to technological advances and the life on the fast track, and there are definite defects in lifestyle now all over the world. People don't exercise, they don't give emphasis to their sleep, their nutrition is not right, and there are many other reasons that people don't take care of their mental health as well as physical health.
So it's because of our hectic routines and also the influx of various technological aspects that has triggered more anxiety and depression within the masses that has caused for a rise in suicide rates.
It has been generally seen that after the World War II, the age of the psychiatric disorders is regressing. Previously, you would hardly find somebody suffering from bipolar disorder under the age of 20. But now it is a very, very common disorder. And there are other mood disorders also which result in suicidal ideation. And then people attempt suicide and few of them become successful in doing so. Although the success rate of people attempting suicide is very low, and that is a fortunate thing. And we can do a lot to prevent it also. In my opinion, and generally also scientific opinion is this, that suicide is the result of a psychiatric disorder mostly. There may be psychological triggers, but to begin with, the idea of suicide generates from a psychiatric disorder. It is a brain disorder, and I can say that it is a physical disorder because brain is also an organ of the body, and when we talk about mental health, actually we are talking about physical health because the crown organ of human being is brain, and if we don't take care of the brain, and there are very special ways of taking care of brain, and people now normally tend to ignore those things, and the lifestyle is such that people don't give attention to their sleep. Their relationship is very bad with each other because the life is fast. We have very little time to negotiate with people and iron out the differences that we have with
so
other people.
A lot of social anxiety is caused because of our lifestyles. Dr. Atishri Bhatti, in India, after almost every hour we hear that a suicide amongst some student takes place. I want to ask you that how and why do you think that suicide rates are rising among students specifically?
Mainly the reason is for the high suicidal tendency among young students and young people in India is because of a lot of parental and peer pressures. And their own expectations are very, very high. The parental expectation is also rising very high. And somewhere the support system is not great at the school level or the college level. That is the reason that the suicidal rates have become
These
high
expectations you talk about, however, what are they related to? Job prospects or educational prospects or other issues?
The expectation can be a self-expectation, a very high expectation coming out from the student itself, or coming from the family or from the parents, or from the family as a whole. So it can be any reason that they are not able to meet those expectations, and that gives rise to all kinds of mental, psychological stresses and anxiety, and then they take this drastic step.
Dr. Ali, we can't just restrict it to this age group there. We've also seen, and the World Health Organization also reports, that people above the age of 70 are also very vulnerable to suicidal tendencies. So we see a huge disparity between the two age groups. What could you tell us a little more about suicides taking place amongst the elderly?
Well, I think that's an excellent question. There is a significant difference in the people who are attempting suicide and who are completing suicide in terms of many different factors, and age is one of those factors. So we see that age of suicide or age of attempted suicide tends to have two peaks. So they have a peak in late teenage or early 20s when people may be struggling with academic issues or careers and things of that sort, relationships. And then there's a second peak, which is after the age of about 60 to 65. And as you pointed out, the elderly are more likely in many different ways. Now, one of the things, I'm very glad that you have somebody from India on this program, because one of the things that Pakistan lacks significantly, in which our neighbor is significantly ahead of us, is population-based research that gives us a good idea of how prevalent mental illness is, how prevalent suicide is. So in Pakistan, we just don't have that research available. We have not done it. We are still not doing it. One of the reasons being that suicide is considered a criminal offense, so it's difficult to do. But the data that you're listening to, the research that you're listening to from us related to Pakistan is really just an extrapolation of Western data. So in America, they've done research and found out that the elderly tend to have more problem with that and so on. Now, of course, in America, the elderly tend to have a different set of stressors compared to Pakistan. So there's more, there's more elderly people living alone. There's more elderly people with no social support. And things of that sort, which is not the case in our country as much as it might be in the West, in Europe or America, things of that sort. But yes, so far the research says that there is a risk of higher completed suicide in the elderly, and there can be a number of reasons for that. As you get older, you develop lots of medical problems. That can be part of the reason. As you get older, you develop more stresses related to people who you've lost. So your parents might have died, you might have lost brothers, sisters, other relatives. You might have financial issues as you get older, you're retired, you're not working anymore, you have stresses. Children might have moved away. So, we are seeing this increasingly in our country, where especially in the cities, there are more and more older people living alone because lots of children have moved away to Europe, to America, to Australia, and so they are all alone by themselves here. So there's multiple factors related to that, I think, really, not just one factor. But yes, it is certainly true that people over the age of 65 need special attention and special care because they can be especially prone to both attempting suicide and completing suicide.
Dr. Ali, I really appreciate that point that we can't just take out numbers from the West and from the world and apply them to Pakistan specifically. Right. But could you elaborate a little more on the cultural and social factors that do cause suicidal tendencies within the Pakistani population?
So I think the fact that we are in fact seeing an increase in the number of suicides is a very worrying one, because our culture actually in many ways is protective against suicide. So all the research that's been done in the West says that strong religious beliefs, strong family systems, social support systems and all, these actually prevent suicide or cause people to not go ahead with committing suicide. So we continue to have strong religious an environment. We still have, even though that family system is changing, but we still have an extended family system. We have social support. there's not really that kind of loneliness and isolation that you experience in the West. But despite all of these factors, we are seeing an increase in the number of depressive cases, increase in the number of suicide. It could be related to multiple factors. So whereas the extended family system tends to provide a supporting factor also, it can also generate a lot of stress. So living within extended family, especially for women, can cause more stress, dealing with the in-laws, dealing with different relatives, so on and so forth. Lack of opportunities for education, lack of opportunities for recreation, lack of opportunities for vocation, unemployment, political instability, social instability, environmental issues, weather problems. We've got the smog going on, heat, cold, electric breakdowns, so many different things,
Dr.
inflation.
Ali, you mentioned how women often in Pakistan do feel more pressure and anxiety due to the the family setup. Dr. Sadaqat, could you tell us a little about the ratio and the number of women who commit suicide in Pakistan as compared to the men? Because globally it's seen that the number of men committing suicide is much higher. Is it different here?
I think attempted suicide is more in women, and men complete it more often. So almost the ratio that goes between men and women is almost the same. And I have seen for the last about 42 years I've been working in this field, that scenario has totally changed. So there is more addiction now all over the world, and in Pakistan there are more mood disorders. And when somebody is suffering from a mood disorder, we take it as a normal thing. It is not a normal thing.
It's seen as being generic.
It has some genetic content most often, and people don't have awareness that if there is a psychiatric illness in their family, there is every likelihood that they might catch it in the future. So we need to create this kind of awareness that if there are more psychiatric disorder in your family, or for that matter more physical disorder in your family, we can look at this and we can do certain maneuvers to beat our genes. So there has to be a prescribed lifestyle that can prevent you from getting the psychiatric as well as physical disorders, and that lifestyle is common to all of these primary chronic illnesses.
So necessarily there doesn't need to be a case where it's inevitable that a person goes down a path where they do develop suicidal tendencies. It can be curbed. That's
yes,
what
definitely. Like when I was studying in medical college and I was in my final year, I started having this insight that there are so many psychiatric disorders in my ancestral family, especially from my mother's side. There was a lot of hue and cry about the addictions in the family. There were suicidal attempts, there were bipolar disorder kind of things, there were murders, and there were things which could be prevented if earlier we can take some action to prevent them. So being a medical professional, early on I realized that I am getting adverse kind of genes from my mother's side. So I continuously, and I was in profession for all that time after my graduation, so I was very conscious that I have to take certain measures, and fortunately, alhamdulillah, I have been able to save myself in that kind of situation where you go for some drugs or alcohol or things like that. I have always followed a healthy lifestyle, and I'm still working very hard. I'm energetic, and it's about 42 years that I'm working in this field, and I encourage other people also to look into their family tree and see if their uncles and aunties suffer from mood disorders or OCD or some kind of schizophrenic kind of illnesses, and they can definitely beat these psychiatric illnesses if they take some proactive action.
We'll go to a short break. When we return, we're going to discuss what individuals can do and if necessarily they can beat the disorders they are perhaps predisposed to or they develop during their time. Stay with us. Hello and welcome back. We're joined in the studios with Dr. Meshal Malik, who is a professor of psychiatry at the Shalimar Hospital. Thank you for joining us, sir. Sir, so before we were going to break, we were talking about how and whether suicide can be prevented. So can you please tell us a little more about it? If people are if they're naturally, if they're genetically wired in a way in which they have a strong family history of mental illnesses, can they still curb their tendencies towards suicide?
I think the biggest problem is that about 90% of patients who do commit suicide, they are seriously depressed. And unfortunately, because we have very poor mental health services, this depression is never identified. And we tend to label people as if they're putting on a show or they're not seriously ill. They're just acting out, so nobody really knows the pain of a patient who is depressed. If you ask me, depression is perhaps the most painful disease known to man. And yet we undervalue its pain and significance.
Just because it doesn't manifest itself physically.
Exactly. You don't break window panes, you don't abuse, you don't become violent, you just sit quietly in a room, you don't talk to anyone, and you are just gloomy and sad and in a world of your own. So people think he will be fine, he'll come out of it, it's just a passing phase, but they don't. And in severe cases, as the depression intensifies, they start getting these terrible ideas that it's not worth living. And in many cases, they then start planning that I will kill myself, and if I kill myself, what will happen to my children? So let me kill them first. So a lot of news that we read in the newspapers is because they kill their children and then they kill themselves. It can be prevented firstly, very important, whenever someone talks about suicide, please take it seriously.
It's a call for help.
It's a very acute call for help. And don't think this man or this woman is just putting on a show. We psychiatrists are very, very particular about this. We specifically ask people about suicide in a routine examination, and if anyone says yes to these ideas, we take them very seriously. So you have to prevent depression, you have to treat depression acutely. And then in our culture, particularly, research has shown that a lot of suicides are committed by people who have financial problems and family problems. Our family system, strangely, may be therapeutic in one sense, but it's very pathogenic in another. And if you come to our wards, you will see patients suffering not because of the neighbor or not because of the butcher or the plumber. It's their mother-in-law, it's their husband, it's their daughter-in-law.
That's something that Dr. Ali also mentioned before, how our family setup is such that it's can be therapeutic, productive in one way,
Yes.
but at the same time it can be extremely damaging.
Absolutely.
We're joined by Dr. Akhtar Ali Said, Principal Clinic Psychologist at the Brothers of Charity Services in Ireland. Thank you for joining us. Before we move forward, I'd like to take a global perspective and talk about how and if mental health care is seen to be a privilege of sorts, even in developed countries.
Definitely, in these countries, the services for mental health are very well defined and provided at a very grassroots level. So communities are having this privilege of being supported by psychiatrists, clinical psychologists, psychotherapists, and so on and so forth. So definitely the situation is far, far better.
But can everyone in these developed countries also afford it? Can everyone reach out equally?
More or less, yes, because the public health services are very well organized, and the system they have evolved is outreaching. So that's why hardly any person who has been diagnosed is missed from receiving the right services more or less at the right time.
Mr. Ali.
Even people with, sorry for cutting you, even people with intellectual disability who are generally marginalized in countries like ours, they are being looked after so well here.
Mr. Ali, the very interesting article I read about a black woman talking and urging other black women to come forward and acknowledge depression. And the fear was amongst developed nations especially that if you acknowledge that you're depressed, that stereotype you have to live up to being a strong, independent black woman doesn't hold. So I'm talking about the nuanced approach here where it might be a privilege for even certain races to come forward and ask for help because other races might not feel as comfortable in doing so.
That might be the case. That might be the case. I don't know the article you are referring to, where that article has been published, UK or some other country.
In the US.
And the US. I'm not talking about the US at all because I don't know their system. I'm talking about mainly about UK and Ireland and the mainland Europe as well. So I'm talking about their system. Yes, US might be a different situation.
In Northern Ireland, seem to be that the suicide rates are much, much higher than in the UK. Can you tell us why? Perhaps that's a reason?
Suicide rate is generally high here in these countries, but I just heard my teacher, Dr. Saad Bashir, who was just talking about the way suicide is being committed in Pakistan. As you know, Dr. Saad will tell you more in detail that the etiology and manifestation of mental health problems vary from culture to culture. The suicide here is mainly coming from a very different reason than what happens in our country. Here, generally, mental health reasons are the major factor, and then sometimes what we see in our clinics, that people are emotionally disturbed. You know that the family institution which you were just talking about when I joined you is not there anymore. So children are being reared up by single-parent families here. That creates a lot of emotional disturbance here. Our young people here in Ireland particularly, they're suffering a lot from attachment issues. So we are talking...
As we discussed before, in each and every country, there's a specific social context which attributes uniquely to causes of depression. We're joined with Dr. Azma Masroor, Head of Department of Professional Psychology at Beria University. Thank you for joining us, ma'am.
Most welcome.
Ma'am, so let's discuss the way forward. Awareness is obviously imperative in terms of trying to prevent suicide, but obviously there is a lack of resources existing, especially in our country. Could you tell us a little about that?
Yeah, thank you very much for inviting me for this discussion. It is really important, and I was really looking forward to talk about such issues on such forum. Actually, we were talking about the awareness campaigns we need to start. I think awareness should have different diversified areas to target. For example, not general awareness about the population itself, like we don't need to talk to the general population, but we need to talk to the parents, the families, and as I recently heard Dr. Akhtar was talking about the family and attachment issues. I think families, different academic institutions, and on different forums, we need to talk about these mental health issues. Now, coming to your point, you were talking about what is the way forward in future. So, my point of view is that in addition to these campaigns, we should add some important elements in our trainings as well, in general understanding about the disorders, and most of all, the adequate training to our professionals, because identifying different risk factors, different signs, different signals from, people around of different ages, I think there should be remarkable understanding and professional training in this field as well.
But professional training amongst the general masses, teachers specifically, in which institutions are you referring to?
I am referring to, we have different types and multiple issues we are talking about in mental health. like different disorders, different psychiatric issues, different psychological issues, and some such situational factors, some psychosocial stressors. There are a lot of things we need to address this. And for that specific purpose, recently we have heard of these suicide incidents in Pakistan as well. So in cultural context, I would like to add that there are a lot of additions into, in our culture as well with respect to these suicide trends. For example, family dissolution is one of the factors, so we can, start working on families as well, talking about this integration in family, the family attachment, the time they spend together, and different type of, I would say, interventions between and type of interactions
Dr.
between the
Uzma,
family.
I take your point, but I'd like to take it to Dr. Ali too. So what's the step forward in terms of resources? It's important that we realize that it's not just identifying the causes. When a person reaches out for help, there needs to be adequate resources available.
Right. So I think, Mishal, going back to the earlier point, so I did my training in the US. I trained for 4 years in Houston, which is a big city. And then for 12 years, I was actually living in a smaller town in the state of Arkansas. So because the government has made mental health a priority in the national landscape, therefore, even the town that I was living in, which was about 50,000 people, plus the surrounding towns, even towns as small as 5,000 people, all had the availability of small mental health clinics where at least a psychologist and oftentimes a psychiatrist was available to provide services for everybody who needed them. And of course, in the bigger cities, those services were much more easily accessible. Now, the fact of the matter is that most of these services were reimbursed by the government. Some were reimbursed by private insurance. But because the government and because the national sort of healthcare priorities were geared towards including mental health in the delivery of health services in general, that was happening. And I think that the mental health systems, as one of the colleagues pointed out, in Ireland and UK and Europe are even stronger because the government has a lot of emphasis on that. Now in Pakistan, our biggest problem, of course, is that not only do we have a very small proportion of our total GDP dedicated to our health budget, we don't have a mental health budget at all. We just don't have it. We don't have a national mental health strategy. We don't have a national mental health or suicide prevention strategy. We just don't talk about it. A few weeks ago, everybody got into this all upset because Pakistan was running out of water, and you couldn't turn on a TV channel without talking about the dams. We had to build a dam. We had to build a dam.
That was seen as a national priority.
So 3 months ago, the dollar lost some of its value against or gained against the rupee, and suddenly it was a national priority that we buy Pakistani things, we reduce our imports. Now, this is something that has to be built consciously. If we can build a consensus behind dam building or behind repairing our economy or whatever, raising chickens in order to improve our economy, we need to do it for mental health also. But unless it's done at a national level, at a political level, at a mass level.
And Dr. Ali, the irony here is that the cost of mental illnesses does damage the economy in a way. So if we don't take control of it, it's going to go into a downward spiral.
Absolutely.
Dr. Saad Malik, I'd like to ask you, what do you think about the fact that we don't have enough adequate resources to reach out to, and the fact that the professionals we do have might not be adequately trained in their fields? So we talked about not being able to diagnose individuals correctly. What can you tell us a little about the state of education in Pakistan in terms of psychiatry, psychology?
Oh, it's terribly abysmal. We have 20 million people who are sick in this country, psychiatrically sick. And we barely have 350 psychiatrists. In the US, the ratio is 1 for 10,000. In UK, it's 1 for 25,000. We have 1 for 500,000. We have almost no psychiatric nurses, no social workers. We don't have psychologists, very few. And the tragedy is that most of the people we train, they go abroad. I mean, in Pakistan, you have 350 Pakistani psychiatrists. In England, you have 760 Pakistani psychiatrists. In US, you have 1,560 Pakistani psychiatrists. So we have to create more psychiatrists, but that is going to take time. I think there is one source which I always feel needs to be tapped. My theory is that in Pakistan, you go to any village or any small town, whether you have water, gas, or bijli or not, you always have a mosque and a Maulvi everywhere. And he does nothing but offer 5 prayers in a day. The rest of the day, that whole building is vacant and absolutely useless. If we could train these people as mental health workers, it's a tall
Process,
order. But they have so much time. And in that time, they do all kind of wrong things which we can prevent them from. And we can train them as mental health workers who could assess people in the community. They could do so much in the community.
Let's bring Mr. Akhtar into the conversation too. Mr. Akhtar, what do you think about empowering social leaders to disseminate more information regarding mental health and also counseling individuals who are suffering from mental health and trauma of sorts?
We can talk about this issue at any length, and I was part of that pilot project who was trying to bring the community leaders like imams, like priests, like counselors, the counselors elected for the local bodies, into this scene to help people, to guide people where to go, what to do. But that pilot project failed, unfortunately. We can talk about this matter, that how we are going to support people who are suffering. Dr. Saad, I think he made a very valid point, is that everybody in Pakistan is suffering. 200 million people are suffering. And you know why? Because we were in a war which was very unique in its nature. And we all suffered the trauma of that war, which went on for more than 35 years. And nobody realized that how this war has affected us. And when we look at the data on PTSD from the conflict regions, Pakistan does not exist in that list because the war in Pakistan was never been identified as a war, as a conflict, as a crisis. This war was unique in 2 ways. One, that we don't know who was the enemy in this war, and we don't know, till today, we don't know what was the reason behind this war. And that war went on, and Dr. Saad and Dr. Ali and Dr. Uzma, they can tell you that if PTSD is combined with confusion and chaos the way it happened in Pakistan, so the impact is terribly multiplied. So this is what we are suffering in Pakistan. If we cannot provide psychiatrists, psychologists...
Mr. Akhtar, I'd like to bring in Dr. Uzma into this conversation as well. Dr. Uzma, what can you tell us about empowering religious leaders? Because one common argument we hear is that there is a conflation of mental illness with being further away from religion. So how can we bring those both things together and create a balance and actually target the issue and problem at hand?
I think it will refer back to that educational enhancement in our country, I think. Dragging my discussion back to that awareness thing, because religion or religious priorities or religious practices, all these things are also related with mental well-being. But in what reference, in what context we can include religion in our, let's say, mental well-being is a really crucial element that is lacking in our training. Because sometimes due to this, culture in our, I don't want to say much about that, but I think there is a predisposition towards, tilting towards the religious, I would say, extremism. That is also causing this chaos because right away you cannot deny anything, and on the back of it you cannot accept it. So sometimes I think religious scholars, they need to be included in these mental health policies and mental health practices where we can, utilize their knowledge. I think their authentic knowledge in this field, we can inculcate, we can include that knowledge into our practices and in our theories, which are referring to a better mental health. I think that is more important.
Thank you so much, Dr. Uzma, for joining us. Dr. Ali, I'd like to move forward and talk about how we can rehabilitate those who are survivors of suicide, who tried to attempt it once and they failed, because that too is very important. And you mentioned how it's still criminalized in Pakistan. So doesn't that just hinder the rehabilitation process?
Oh, it's not just a hindrance. I think it's an absolute obstacle in trying to help people, both of those who are suffering from thoughts of suicide and may attempt suicide, or those who actually have attempted suicide. Or, for instance, people who've committed suicide and then you're trying to help their family members or their friends or people who've been affected by their suicide. So, yes, absolutely, it's a huge obstacle. I think decriminalizing suicide would be a good first step. That's certainly something that the government should do immediately. Not only would that open up the area of doing more research on suicide, but also doing outreach for people who may be suffering from that. Other than that, I think, as Dr. Saad has pointed out, that suicide, even though it's a terrible occurrence, is in fact just sort of the tip of the iceberg. It is the last event in a long series of events that have been happening over a period of time, sometimes going back a number of years. So you have people who are under various kinds of stress, family stress, financial stress, social stress, education stress, students, so on. At some point, they might become hopeless and think that things are not going to improve and might start developing symptoms of depression and then develop clinical depression, the illness of depression as we were talking about. And if that persists and that's not recognized, it's untreated, they're not provided the help that they need, then that is something that will eventually culminate probably in a suicide attempt. So I think we need to intervene much earlier than when a person attempts suicide. Certainly, after they attempt suicide, and even before that, as Dr. Saad has said, even if they start talking about suicide, if they're expressing thoughts of suicide, we absolutely must take that very seriously. But I think that needs to begin much earlier, particularly in response to some of the high-profile suicide attempts on campuses and in young people. I think it's absolutely a disgrace that our university campuses and our college campuses and our school campuses are not doing anything, not just doing more, not doing anything. So we've had this suicide at Beacon House Science University. In my clinic, I'm seeing students and teachers from BNU every day who say we need help. Well, why is the university not providing help on campus? Why is not big private universities not doing that?
And these are elite universities.
Elite universities charging lots of money for providing education. Well, mental health and part of the, I mean, I hate to sort of play a blame game here, but the competitive, you mentioned that you'd gone to a particular university. The atmosphere, the competitive, sort of driven atmosphere at that university, at those institutions, actually promotes that kind of behavior, promotes depression, promotes stress, and can lead towards suicide. So I think the universities need to be colleges, universities need to be doing a lot more.
It's all about a matter of priorities.
Yes, prevention and rehabilitation.
Stay with us. When we return, we're going to discuss how we can rehabilitate individuals who are suffering from suicidal tendencies and those who attempted to commit suicide. Thank you. Welcome back. Before leaving for break, we were talking about how we must rehabilitate those who are suffering from suicidal tendencies, those who are victims, family members, friends who have lost a loved one, and those who attempted suicide and failed. Dr. Sadakat, this seems to be a very, very complicated issue, and there seems to be no end to it because we see that people who are experts are advocating for institutions to take control. Have you seen in recent years the government or several institutions taking steps that are in the right direction?
I don't see any step taken in the right direction for the last many, many years. And we have many other issues which take precedence over the health issues. Suicide is the result of many psychiatric disorders, mostly psychiatric disorders which involve deep depression. And we need to distinguish between the feeling of everyday depression and the feeling of depression that comes from adverse circumstances, and the feeling of depression which is deeper than that and that emerges from the serious psychiatric disorders like endogenous depression or depression that is there in the manic depressive illness. So if we start recognizing these illnesses in people in our family, then a lot of preventive measures can be taken. So it is a taboo, and we don't recognize psychiatric illness in the family. Even if some patient comes to us and we need to explore the family history of psychiatric illness in that family, we are faced with a lot of difficulties because they don't want to disclose these similar psychiatric illness in their family. So after we explore it quite with a lot of effort, then we just find out that there are clusters of similar patients in the family. So having psychiatric illness in the family is considered to be shameful. Like all illnesses are illnesses. There are not prestigious illnesses.
But emphasis here needs to lie on the fact that it's important to intervene and to treat these illnesses rather than thinking of it as a taboo and not even discussing them or even seeking help for them.
Yeah. Like heart disease is considered to be a prestigious illness. Diabetes is also okay, but having bipolar disorder or having depression or some other OCD, people would not like to admit to even close friends that they suffer from obsessive compulsive disorder. And most of all, now you see that drug addiction is on the increase for the last 40 years. And it is an indication that the psychiatric illnesses are not being treated, so the result is self-medication that we call drug addiction. So when people have stress, when people have depression, they would tend to drink rather than go to a psychiatrist and be labeled as a psychiatric patient. So we need to create a lot of awareness in our country.
Dr. Saad, you mentioned about taking cries for help seriously. So and this is something that a lot of people struggle with, that they didn't see it coming when someone commits suicide. But I want to ask you and your expert opinion that people who are right on the edge of taking their life or committing something, committing an act of that sort, do they give off signs that people around them should identify?
Yes, but I think before I answer that, there's something else I like to say. We should not give the impression to the public that mental health is something black and white, that you either are sick or you are not. Most of the people that we meet are people who are not necessarily mentally sick, but they're also not well. And these unstable people constitute what we call unstable personalities. And I always advocate that compared to physical health, mental health is far more serious, because not only do you suffer yourself, your whole family suffers with it. And if you happen to be a judge or a politician or a bureaucrat, everybody suffers who works with you. If you're a politician, the whole country suffers. Whereas if you're a diabetic and a politician, well, it's your problem. Nobody else suffers. So it's really a paradigm, it's really a continuum from positive mental health, where you have peace, you have tranquility, you have satisfaction with life.
It moves outwards.
Yes, to somebody who's completely unhappy, but not necessarily ill. Now, coming about the signs are usually, they're very interesting in fact, because when a depressed patient suddenly shows a sense of relief and says, I am okay now, that's a dangerous sign.
Because depression isn't cured overnight.
No, but that means he has sorted something out for himself. Or when you find somebody is collecting his or her pills, they're not consuming them, but they're just accumulating them. Or when you find a suicide note that has been hidden somewhere, or when somebody is preparing for some kind of a measure to use to kill himself or herself. It could be hanging, it could be drowning, it could be medication, it could be anything. This is why I think we'll all agree here that the one advice we give to every family of a patient who's depressed, please watch him, look after him, don't leave him alone, don't give the tablets into his hands or her hands. You take control of them and take every cry for help seriously.
But also the issue is that those who are severely depressed do move towards isolation, self-isolation. So in that case, what should society around them do? Because these people are resistant from meeting, from socializing. They aren't very open to discussing their feelings anymore because they see it as being hopeless. So what can people around
there's
them
a
do?
lot going on apart from isolation. I mean, if you talk to them, they'll talk about doom and gloom and hopelessness and helplessness and guilt and no desire to live. I think these are things that really should alert you that this
Something's
person
not
is
right.
not well. Yes.
I think, Mishal, we should remember that the unfortunate young woman who did commit suicide, Roshan, the girl at Greenview, in fact, there were plenty of signs that she was getting very close to the edge. She had made multiple, I've seen on social media and Instagram posts that are circulating in which she talks about that if she dies, she wants people to remember her smiling and all this and this. So there were indications that she was reaching out. She was asking people, or she was in an indirect way, she was wanting help, but nobody was listening. Nobody was paying attention. So I think the family sort of overlooked that. Her friends didn't really pay attention. The university certainly failed her in a terrible way, and it should have been picked up. So it didn't happen out of the blue. And that is the case with most people who are contemplating suicide or actually go ahead and attempt suicide. They will send out signals of various sorts. It's just a matter of making sure that you're sensitive to them so that you allow them to open up and to speak about it. And once they start talking about it, then you've really de-escalated them to a significant degree. I mean, you can really be much more at ease that now you can be, you have a little bit more time to work with them. It's when they're cut off and not being listened to and not being paid attention to that something like this might actually happen.
And the issue with social media here is that anyone who expresses their thoughts on it is seen, their issue is trivialized by those around them. They aren't taken seriously enough. And one of the things that I personally feel is imperative during the rehabilitation process, especially of friends and family, is to be sensitive on these platforms. What can you tell us a little about people who express their condolences, their grief on social media, but how it can potentially be insensitive to those who are suffering and grieving around them?
I think the fact of responding insensitively to someone who's suffering from a mental illness or things of that sort is actually a reflection of the general lack of awareness and lack of education and the lack of and the general stigma in our society, which is not something that can be addressed by talking to one person or talking to one family. Again, that requires a national awareness strategy, education strategy. Why aren't we teaching about mental illness in schools and colleges, universities, all of these places, to sensitize people? I mean, we talk to people about the environment, we talk to children about cleanliness, we talk to children about Islam, we talk to about so many different things, starting from when they start school at the age of 5. Well, why aren't we doing that with mental illness? Because if we did, in less than a generation, we would not be having too many people who would be saying these kinds of things on social media. So I think it's a good thing that people are expressing condolences or talking about mental illness or expressing what they feel about their own mental health or other people's mental health in a sympathetic way. That's a good thing. I think it's probably a balance.
Okay.
There are people who are opposing it, but that hopefully will gradually begin to change.
Dr. Sadakat, what do you think about the fact that when media and social media platforms in a way glamorize suicide? Because we have seen series that are, for example, 13 Reasons Why that came out and which glorified suicide and especially created a stir amongst young people who are much more impressionable. What's the responsibility incumbent upon media outlets?
Actually, there is an unconscious message when they see things being glamorized. The message is that suicide is something that is regularly being done and there is nothing strange about it. Like divorce, there is a saying that if 3 of the friends of a girl get divorced, the 4th one is automatically thinking on these lines. So when we glamorize something like this, which is tragic in fact, there is going to be negative consequence about that. When somebody is having suicidal ideation, he is also struggling against it at the same time. And we need to invent the phrases which people can use at that time when somebody discloses his internal pain and there is a cry for help and somebody talks about going on a long journey or showing that he has finished his life and now he has no interest in life. So what we need to do is put a little of our weight on the side of struggle that he's going through and we be supportive with him, and just a little bit of help will change the balance towards life. So if somebody is going through this idea that he should finish his life, he is also struggling against it every day. And with every passing day, he is also inventing reasons to live. So if we help him a little bit and also take him for treatment, we are definitely going to save a lot of lives.
Dr. Saad, how do we assimilate those people who are depressed and who don't want to reach out? What can we as a society do to help and prevent them from taking this measure?
I think the first thing is we need to change our attitude towards mental illness. We all have this experience that the moment if you ask someone to see a psychiatrist, the first answer you get is, am I mad? And I think my friends will bear me out that probably 5% of the patients we see would be what you and I would call mad. Well, we wouldn't call them mad, but they would be psychotic. The rest are people like you and I who are struggling with life. They are trying to make two ends meet and they're coping with stresses, relationships, issues. We need to have a positive attitude towards them. The other thing that I feel very sad is that we have a very negative attitude towards someone who has attempted suicide and survived. Rather than give them compassion, we start hurling out religious creeds and condemning them for what they have done. And if they have died, we don't even want to lead the namaz-e-janaza. I mean, we need to look into that.
And a person who's already attempted to commit suicide is more likely to...
Oh, absolutely. Absolutely. So even one who has attempted genuinely or even otherwise, they have a very serious risk of repeating it.
On that same note, Dr. Ali, what would you like to say? What can we do for young people, for old people, for people of all ages, all races? How can we try and work and take care of them better?
You know, I think we've talked about most of these things, but I think it's past time that we should be declaring a mental health emergency in this country, a national mental health emergency. You know, we've declared a dam emergency, we've declared an economic emergency, but we should be working on this also, because this issue is not going away. Despite all the protective factors in our society, we've come to a stage where we've reached that stage of development where these things will have to be addressed. Otherwise, we'll be seeing more and more of this in college campuses, in office spaces, in workplaces, in homes. So mental health is not an issue that's going to go away. It's a global issue. It's increasing all over the world. And it's going to increase in Pakistan also. Just pretending that it doesn't exist, pretending that it's not a problem is not working anymore. And if, you know, we are so concerned about our water, we are so concerned about our economy, why are we not concerned about the future of our young people? Why are we not concerned about the future of the people who live in this country, especially, like I said, the young people? So if we are losing hundreds of young people to suicide every year, is that not an emergency? Should that not be talked about in the media, on television? Why is Parliament not talking about that? Why are we not taking war measures to address that particular emergency? So that it's something that needs to be addressed, not just at an individual level, community level, me talking to a person or somebody else talking to a person, but at a city level, at a national level, at a policy level. We need to come up with a national mental health policy that addresses these issues going forward.
Dr. Sadakat, what would your message be to policymakers regarding mental health awareness? What should they be doing?
I think the media is doing a lot already on the subject of awareness regarding mental health and other illnesses which are psychiatric illnesses. But it is the duty of the government that as they design the physical health of the nation, they also take some budget to the mental health as well. Because I haven't seen during the last 45 years I've been in this field that government has done anything seriously about mental health. So World Health Organization is spreading the message all over the world that we need to take care of the mental health of the people. But today we have been talking about suicide, but we have missed out at one point, which is deliberate self-harm, which is very common amongst the teenagers these days. And when somebody does this, family probably thinks that he is seeking attention, although he is seeking
Cutting
attention.
Your arms,
yes, but it is a serious sign, and I would like to ask Dr. Saad.
Yes,
to throw some light on it, that does it have any relationship with suicide also in the later part
Dr.
of
Saad,
somebody's
please
life?
tell us a little about that.
You see, basically, we are dealing with three things here. One is what we call completed suicide, that you attempt suicide and you die. The other is when you genuinely want to kill yourself and you survive by accident, that is attempted suicide. And the third is when you really don't want to die, but you want attention and you want somebody to, a relationship issue or some other family problem, and you want people to take care of you. That is called deliberate self-harm. There you make sure that you take enough pills that don't really kill you, but they still give the kind of care and attention you want. Here you have two kind of problems, because sometimes these habitual people who deliberate self-harm, they may take an accidental dose which is too high, and they actually may die when they don't intend to. And secondly, their lifestyles are so disruptive and they're so unstable that they eventually do kill themselves. So we still take those self-harm attempts as serious.
So it's imperative to always listen to someone who's reaching out.
Absolutely.
And if they're not even reaching out verbally, we should be aware and cognizant of what's going around us and what's happening and how people are suffering. Thank you so much, Dr. Saad, for joining us, Dr. Sadakat, Dr. Ali. It was a very insightful discussion. I hope this discussion today was helpful, and if you are suffering from any mental illness, please do not fear from reaching out to those around you, and especially a professional. Hope you liked today's episode. We'll see you tomorrow. Thank you.